Record. All right. Well, I am so excited. We were just talking before we hit the record button, and I know that from the past that we end up having our best conversations before I hit record. So I was telling Jeff, I'm like, you know what? Let's just go ahead and let's go ahead and get started. You all are in for a real treat. We are here with Dr. Jeff Young, and I'll give a little bit of an intro, and then he is here, just kind of bottom line up front. He's here to talk about his therapy style or therapy called No Bullshit Therapy, NBT. So that's going to be our topic for today is NBT. And hopefully, if we do our job right, listeners, you guys will be able to take away some nuggets and hopefully some inspiration to read his book, because I already got nuggets from this book for my role as a BHC working in primary care behavioral health. So Dr. Jeff Young is the director of the Bouvier Center. How do you say that?
Bouverie Centre. I
Bouverie.
retired from that role a year ago, but I was there director for 14 years.
Okay. You were there, and that's in Victoria's Family Institute at La Trobe University in Australia?
Yeah, in Melbourne.
And he's a clinical psychologist. He's worked, published, and presented in the area of mental health for the past 3 decades. He has shown a strong commitment. Here we go. A strong commitment to accessible, contextually compassionate health services. So if you watch our PCBH Corners, and we've actually had the joke that it's a little bit of a drinking game for every time I say the word contextual. If you watch our stuff, you're gonna like Dr. Jeff Young here. So yes, strong commitment to accessible, contextually compassionate health services. He's generated a lot of interest in no bullshit therapy, which is an approach to counseling he developed, which accepts that lots of people hate counseling or aren't into counseling or are counseling naive. However you want to say it, they didn't necessarily sign up for this. And we'll let Jeff talk a little bit more on this approach, but I'm going to read a couple other lines here because I just thought they were so good. Most simply, no bullshit therapy is about being authentic, even in difficult situations, which I hope that us as clinicians really take to heart. And then this is another really good nugget here, creating a context for mutual honesty and directness, sometimes just by stating that is how you like to work, can be very effective, especially with people who are suspicious of counseling or distrustful of the counselor. When combined with warmth and care, honesty and directness can enhance intimacy, connection, and trust, especially if the counselor avoids jargon and is respectful of the constraints to the work. So, like I said, he has written a book, and he wants to help you all, get some takeaways. So is there anything that I missed so far, Jeff, that you think would be really important with regards to the book or your introduction or your background?
No, that's fine. That's good. And just to say, I've really become an admirer of your work with David too, and the whole role of the primary care behavioural health, just being able to be so responsive and connected with GPs is, I think, a great idea, and you're getting the results. So yeah, we can learn a lot from you guys.
Well, we appreciate that, and it's so funny how our work are in different settings, and at the same time, as I was reading the book, scenario after scenario after scenario, I literally was going through my head as a clinician and being like, I've been in this situation. I've been in that situation. I see what you're saying. Like as you go through the tenets or the you call them mandates, the tenets, the mandates, the principles of the therapy, there's so much that I felt like I could immediately take and use. In fact, already have. I had clinic yesterday and I had finished up the book this past weekend, and I'm already utilizing certain nuggets to be more direct and more honest, and just kind of putting it out on the table with some folks, some of them that I've worked with for a while, and then some of them that are, I've maybe met with that day or a couple times.
Yeah. Oh, that's fantastic. I'm so pleased.
Yeah. Okay. So I have some questions here.
Go for
Is
it.
that okay if I jump in?
Yeah, I think once you describe yourself as a no bullshit therapist, it one makes it more obvious to yourself when you're not quite telling the things directly and honestly or obfuscating, and also creates a natural context for honesty and directness. So I couldn't be promoting this work and say go easy on the questions. So yeah, go for it.
I love that. I love that. Okay. So, um, one of the lines that I love so much that I wrote it out here in my notes was what helps to adopt I can take it or leave it stance is to realize that this is the reality, not necessarily a strategic strategy, but naming the situation as it is. I acknowledge and accept that realistically, I can only be as helpful as a client or patient, in our case, we say patient, will let me. So basically, in the book, you talk about you go in, it's like your stance, right, as a clinician, that you take it or leave it. Uh, and you're not you also talk about the clinician not being emotionally dependent on the outcome of the therapy. So I just thought that was I feel like that's something that we're talking with our trainees about constantly is that you could be invested but don't be emotionally dependent on somebody else getting better. And the whole thing of like, hey, I'm here to help you, but you can take it or you can leave it, and that's okay to have as a stance, and that's not conceding to say, oh, I don't care as a clinician. So I was just wondering if you could talk a little bit more on the you know I can take it or leave it stance,
Yeah,
and allowing patients to take that stance.
yeah. I probably need a little bit of to give a little bit of context to that first, um, because in some ways, um, like most therapists, want to help people, want to see them live better lives. So we are. Let's not pretend we are totally invested in our patients getting better. Um, but it took me, and I love therapy. I decided to make it my career. But it took me probably almost a couple of decades to realize that not everyone else in the community shared my love of therapy. And there were some people who were so far along the continuum of disliking and distrusting therapy and therapists and the services that provided them that I started just uh, in a way to have, I started calling those clients or people therapy haters, and they're the other extreme therapy lovers. And in some ways, they're harsh terms, but they're terms to uh, help us have the conversation I think we need to have. That there are very different approaches to therapy out there in the community. And what I realized writing the book was that most models of therapy
Hmm.
are designed by therapy lovers for therapy lovers.
Oh
And when
yeah.
they don't work, and therapy lovers are, they voluntarily seek our help, they're invested in the therapeutic relationship, they trust us essentially, they've often got word of mouth, they come with in good faith. Um, so they they are going to um, approach therapy in a very different way to someone who's a therapy hater, who's often been forced to attend. They don't want to attend. They're not trusting. They might have been traumatized in the past or traumatized by the services that they've got, or they might just not think that therapy is for them. And they're usually, because they've been pressured in some way, they haven't sought out the service, so they often come in bad faith. And so um, when therapy haters don't, when the voluntary work that works with therapy lovers, beautiful things like the single session questions, beautiful. What would you like to walk away with by the end of today? Works beautifully with a therapy lover. With a therapy hater, if they were to be honest, and you could hear what their thought bubbles was, they'd probably say, I just want to walk away from this. You know, how would you like to work? I just don't
I
want
want
to
it.
work with you anymore. So when the voluntary approaches don't work, I think our field tends to pathologize therapy haters and say that they either don't want help, they're avoidant, you know, too defensive, whatever. So no bullshit therapy is really designed with therapy haters in mind. And I've got a line which I quite like, that therapy should fit the client or the patient. The patient shouldn't have to be expected to fit our mainstream models of therapy. So almost the opposite ways of engaging a therapy lover work with a therapy hater. So being honest and upfront, direct and businesslike, and in a way taking the stance that you're not emotionally invested in them working with you. That's where your question came. That if they decide not to work with you, you'll be okay. You won't be bereft. So your sense of self, your sense of professional competence isn't dependent on them working with you. Now that seems harsh to the way we've been trained, but, and I've seen this in so many sessions and so many role plays in my training, what that means is that the person then thinks, oh, this isn't for Jeff. Well, it must be for me. And I can decide whether and how I want it. But it's not just totally giving the person what they want. You have your boundaries and limitations. And so then it's up to the client to decide whether they want to work with you or not. The irony is that allows you to be more direct and more upfront about how this might be helpful. And also, if they don't accept the help, which is their right, you point out the consequences of that very directly and very clearly. So the actual outcome is more engaging, even though you're not invested. So that was the context I wanted to provide.
Yeah, I mean, I think that, you know, how you're saying that it can kind of be taken as harsh. I think it's actually really healthy for us as clinicians to respect folks' autonomy, and even more than respect. In this case, I would say that you're raising that to the forefront. You're bringing that to the table of the. I mean, am I interpreting that right? That like you're really making their autonomy really obvious, that they can choose what they want to do.
Well, it's a bit more nuanced than that. Ronald Rooney had a really nice line, and he wrote a book also like many years ago on engaging people who didn't want to, didn't see themselves as patients, didn't define themselves as patient, didn't accept the definition of their problem that the referring agent would have had, or that the therapist initially has in their intake. He said, you've got to try and provide as much agency and choice as possible.
Okay.
But when there are issues that can't be of free choice, be as very transparent and clear and specific and direct about those. So sometimes they're legal issues.
Right.
Sometimes they're issues like, for example, if someone comes in and they've been forced to attend therapy by their partner, you know, essentially, look, you go to therapy or I'm out of here.
Right.
So they come along, they don't really want to do any work, they don't believe in it, they're just going along hoping that if they go along, that'll satiate their partner's concerns. Now, often you get that sense that the person's not really wanting to work or not being very upfront, and you sort of feel like it's not working. And so what really works in no bullshit therapy is to really make upfront that maybe the person didn't want to come along. This is the last place they want, and is that right? And then to say, and you sort of break the rules. You rather than sort of say, oh, socially get to know the person and be friendly, because a therapy hater will see that as trying to engage and manipulate them so that they'll, to get them to do what you want. So a business-like approach is helpful, but also to acknowledge the constraint that they don't want to be there up front and make a feature of it.
Right. I like that line.
At least this guy's not naive. They still won't trust you. And then to be really transparent but clear and just say how you like to work. So not collaborate at that stage, because collaboration is disrespectful because it assumes the person wants to work with you. So if you accept they don't want to work with you, then you say, well, okay, well, this is how I like to work. And the easiest way to negotiate and how to work, or say how you're going to work, is, look, I like to be really upfront and direct. And most therapy haters will jump in really quickly and say, yeah, well, that's the way I like to work too. And so then you build on that. Okay, so that's great. So I'd really want you to be honest and direct with me. So it's creating that context for mutual honesty and directness. It's not just one way. It's
right.
Mutual honesty and directness. So where that helps, if someone's really sort of maybe aggressively hating therapy, sometimes, they'll sort of just jump in and say, look, I think this is bullshit. This is hopeless. This is not going to work. It's a load of crap. Often the tendency is to go, oh my God, get defensive, feel worried, get frightened, nervous. An easy way of saying, oh, great, you're upfront and direct. That's the way I like to work too. That's fantastic. I think we'll get on fine. But is it okay if I'm direct with you, honest and direct with you too? So usually you can engage at that level. Then, like single session and most good therapy, the next task is to work out what that client or patient, the therapy hater, really wants. And that's more complicated. There's a lot of detail of how to find that out. But let's say you finally get to the fact that he wants to save his marriage, going back to this example. Then you can say, okay, are you serious about that? So you can emphasize and really find that out. So you want to change your marriage, you want to save your marriage. Yeah? Well, maybe I could maybe help you. That's my area of expertise. But it would mean that I'd have to ask some maybe pretty sensitive or difficult questions. And remember, I said I'd be upfront and direct. You can be direct with me too, but I said I'd be upfront and direct. So you sort of use that agreement, contract, sort of mandate, which is the first clinical guideline, mandate, establish a mandate of how to work, honest and direct, easy. What to work on, more difficult, but what the client really wants. Or even to work on anything at all. Like you can walk away at any time, it's voluntary. Even if the person's been referred, say, by a legal system or a parole officer, we call it parole officer in Australia, you still say, look, you can walk away at any time. I will feed back to your parole officer that you came, but I'll be honest, as I said, professionally, I'll be honest. I'll just say, look, he came, we didn't do any work, but he came, and that's probably not going to be terribly helpful for you. So that's where you're very clear about the consequences of not engaging. And so that's how you can start to build a trusting relationship, honesty and directness, and a productive relationship, giving the person as much autonomy, but being very specific about the non-negotiables.
Yeah, I really liked how you talked about being upfront with the constraints or the limitations on what's going on. I had in my notes here that, again, as we said, we work in different contexts, us in general practitioner office, but I really resonated with the fact that many people who are seeing us in primary care behavioral health aren't necessarily seeking out to do so. So whether it's a chronic pain contract that the PCP is basically making the patient do in order to continue getting medication, or the PCP or GP is looking for needed support and they finally oblige and say, sure, fine, I'll talk to this person. I really did the way you have it written in the book about being upfront with constraints, being upfront with the limitations. And then, as you write about, just really, again, eloquently in the book, about making it a feature. So any difficulty that you're having in a relationship, so you're going to see somebody for a chronic pain contract. It's very clear the patient doesn't necessarily want to see you based on their nonverbals when you introduce yourself, or maybe your PCP was able to give you a snippet on it. Instead of hiding, as you talk about, instead of hiding behind like, oh, well, I'm a nice person, you're a nice person, like, well, let's work together and get you what get us somewhere with this and support you, to really call attention and make a feature of that and saying, like, right up front, like, I know this is a difficult context that I'm coming in for, and this is kind of a mandate situation. So I guess I just really resonated with that. Did you have any more thoughts on making those constraints or those limitations or the difficulty of an interaction a feature? Or, yeah, just any more thoughts on clinicians doing that?
Yeah, I think from family therapy, I got the idea that if you name a constraint, it softens that constraint. And from Nancy Black, who was a director, film director of some training videos, pretty elaborate training videos I did many years ago, she said that what people in the film world do is, if you can't hide an imperfection in your surroundings, you make a feature of it. Because if you try and avoid that shadow, everyone looks at what you're trying to avoid. So if you're trying to avoid the fact that, say, a chronic pain patient is directed to see you and they don't want to, and they've probably been through so many services without much help, they come along thinking, well, they've sort of got to try something, but knowing it won't help. So if you avoid that, that's the thing that they're going to really focus on. This is going to be another unhelpful approach. But if you make a feature of it and really put it on the table, it relaxes you as much as anything, but it also makes the patient feel, oh, at least this person is really upfront and direct, and they aren't going to pull their punches. So, and then with an invitation for them to be honest and direct with you too, you're actually simpatico with that guideline. And Barry Mason, who has passed away, but he was a colleague in the UK, he actually had a chronic condition, spondylosis or something like that, I think it was. He used to say, let's say we spend this time together and I was of absolutely no use to you whatever.
I remember reading that in the book. That was good. That was good.
Yeah. So I think the no bullshit approach is to sort of say, look, I get the impression that maybe your GP was keen, more keen for you to come than you were. That's fine. And I imagine that you've been through this, a whole lot, and you probably think I'm not going to help anything, do anything. I'm probably not going to be helpful to you. Can I be upfront and direct like that? And people say, yeah, well, look, that's good. And that's exactly the way I feel. And say, well, good on you. that's great. Great that you're upfront and direct too. I think we'll get on really, really well. And because I don't want to waste your time, which again, it's quite upfront. With people that are really strong therapy haters, I also would say, and to be honest, I don't want to waste my time either.
Mm.
Again, it's very upfront, but it conveys, one, you're true to what you're saying, you'd be upfront and direct. Also, going back to what we said earlier, I'm not invested emotionally in this working. I really want to help you. So it allows you to be even reach in and sort of say, I want to help, rather than be, strategically stepping back and trying being hard to, it's actually allows you to be more direct. So if I really want to, I think I can do something that might be able to help you. And no guarantees, and you probably think nothing will work. And you don't want to really be here. But what is it that if I could do some little thing that would be helpful for you? Not what your GP wants, what you want. And so once you get that, what they want, I make a bit of a mantra and say everything I'm doing is to help you get what you want.
Yeah. Over and over. Yeah. Over and over again of like, we're doing this because of that. And I think that that's huge. And it's in so many different therapies. And it makes sense because as human beings, we don't fight our own ideas. We don't go against our interests. If we're really able to illuminate what's deeply meaningful and important to us, then we're kind of aligned on that.
Yeah.
So, there's none of that, that friction.
And I think that's the power of the single session approach, of finding out what the person wants and responding to that. But when there's a therapy hater who really doesn't want to work, finding that out and making that, emphasizing that, is also then built on by saying, going back to the previous example we were talking about, if you want to change, if you want to save your marriage, I'm going to have to ask some really difficult questions, even ones that you might find hard to hear. Are you serious enough about wanting to save your marriage to be able to put up with that? So you really emphasize sort of the constraint.
Yeah.
You emphasize it, and also you give yourself the power and ability to be able to do the work that you sign up for. So what I mean by that is, often clients will say, I want you to save my marriage, but I don't want to talk about my violence. And you go, us therapists often go, yeah, we'll try and work and see what we can do. As soon as you agree to that, it's not going to work. So you actually have to negotiate an agreement, a contract that allows you to do what they want, to achieve what they want. And so you say, look, but you keep emphasizing it, sort of like a marker for the difficult issues. Now, you said you wanted to save your marriage. I'm going to try my best to help you do that. But in order to help you save your marriage, I'm going to have to ask you about your violence. And then that's where the second clinical guideline comes in, marrying honesty and directness with warmth and care. And I do this all the time just because it's integrating the two. So you might, and with therapy haters, you have more honesty and directness than warmth and care initially. Yeah. The Lorenz attractor. Yeah.
Yes.
Lorenz was a meteorologist trying to predict the changing weather with multiple variables, and it created that beautiful image. You can look it up on the web. Became an icon of the chaos theorists. Anyway, but it's not the shit sandwich of say something nice, then say what you really think, and then something nice to finish. It's a really integrated, and it might be say, look, good on you for being able to, cope with a question like this. A lot of people wouldn't, but that's what's going to help you save your marriage. And that's what you said you were really keen to do. And I'm going to work with you to do that.
Do you feel like this? So you talk about in your book, motivational interviewing and rolling with resistance. And then, we had mentioned about the stance. I guess, being a clinician now practicing for a little bit over a decade, it really has helped me a lot as a clinician to not use these things as strategies anymore. Like I think when I was first learning about rolling with resistance, it was like, oh, okay, I'll roll with resistance so I can help roll with it and get us in a place. And then once I'm in that place and I can increase the ambivalence, and then it really is at the end of the day, it goes back to, it really is about me as the clinician. And as our good friend Bob Rosenbaum always says, turns out therapy isn't about you as the clinician. It's about the patient. Like, it's not about you. So, the way that you're talking about, aligning, really getting at the heart of what people want, getting informed consent, essentially. If this is what you do want, this is kind of what it's going to take, being really upfront, making the feature of the constraints, all this stuff. Talk to me a little bit just about the stance. Like, am I on the right path, that the stance really is like, hey, this is your life and I do want to help. And I know that you wrote in there about motivational interviewing that you don't act like you don't want to help. If you do want to help, you do say that. I guess this isn't really much of a question other than just talking about the stance of the NBT. Like,
Yeah, no, I think it's a really lovely question, and embedded in it is a really common aspect of, I think, a lot of therapists, that you learn strategies that work, and you're strategizing, like if you acknowledge that, maybe you can't help, the person will lean in and say, well, oh, maybe I do want this help. But there is a subtle but powerful difference between having that as a strategy, trying to engage the person, and realizing that that's the reality, and you really believe it, or you really understand that that person can walk away at any time. It's more authentic, it's more respectful, which then, one, it just makes you feel better that you're living true to your values.
Right.
But two, as a clinician and as a person, but I think it also allows you to delve into more complex and difficult and more sensitive and more shameful, like issues of that where the client and patient might have shame or be traumatized about. It allows you to deal with those in a very authentic, upfront and direct way. So you get this sense of simpatico of therapist and patient being on the same level. And that's a good thing in itself, but it's also particularly important where people have been traumatized, because, as we know, there's more real estate in the brain dedicated to our survival, and especially our physical survival. So when someone's been traumatized, when we're talking with a therapist, that person is going to be focused on, are there any threats here? What strategy is the person the therapist trying to use? I've seen that one. Yeah, be nice and warm and engage. I've seen that before. But also, what is the therapist not saying? What do they really think of me? What do they really think of what's going on here? So there's a whole lot that the traumatized brain is focused on that gets in the way of being able to focus on the logical, collaborative, helpful discussion. So the more authentic you are and transparent about what you really think, providing a marker beforehand. You know, I told you I was going to be really direct, and a context. It's only because I want you to help you save your marriage. Then, and I'll tell you what I think you should do. You might not like it, but I'm going to share exactly what I think, so you at least know what I'm thinking, even if you don't like it. All of a sudden, a whole lot of that neural physiology is freed up to be able to start to focus on the helping conversation, and it creates more trust, that upfront, direct, and no jargon. Avoid jargon is the fourth and final clinical guideline of no bullshit therapy, and that's around avoiding obfuscation. It's not anti-intellectual, but it's about avoiding jargon. And we can fall so easily into jargon. Might not feel like jargon to us, but for someone outside the field who's suspicious of the field and us, it is easy to fall into that jargon. And then they've got to try and work out, well, they're saying that, what's the therapist really thinking?
When it comes to developing that authenticity, from what we've seen and what I've experienced myself, is definitely a developmental process. Because in the beginning, as a new clinician, you're so worried about doing everything right. Did I ask the right questions? Did I match my nonverbals? Am I charting the right way? And you're really fixated on. And then, of course, in your head, you have all these different strategies that you're trying to utilize. And I don't know when exactly it happened for me. If I had to put a number on it, say 4 or 5 years in, maybe all of a sudden, all those strategies really did transcend to where I just felt authentically, we talk about being curious about what's going on with the patient. We talk about gathering the context. And now when I go into a visit, truly, I don't have an agenda. And other than I really want to learn about this patient. I really want to know what's important to them and see if we can chart a path. And so now when I say these things, it probably comes off as a lot more authentic because I actually mean it. Can you talk a little bit, are you finding the same thing developmentally as you go over this NBT approach, that in the beginning, maybe folks are really fixated on doing all the right strategies or remembering the 4 guidelines, and then can you just talk to that process a little bit, and maybe what we as supervisors or trainers can do to help increase novice clinicians' genuine and authenticity?
Yeah, I think partly it is a developmental phase. You sort of, in a way, learn strategies and guidelines to be direct and compassionate and upfront, and then gradually you embody that.
There you go. That was a really good way you just said that. And you embody it.
Yeah. I think some things that are helpful to keep in mind too is, one is that clients are more likely to want honesty and directness than therapists initially. Patients, I keep saying clients, clients.
Clients is fine.
Patients are often more wanting to know what the therapist is really thinking, and to be very direct about the difficulties. And it's direct without judgment. And often that's tone of voice. The difference between, okay, so tell me why your wife thinks you should be here. I'm not necessarily going to take her word, but if you're going to help save your marriage, it's helpful for me, but it's even more helpful for you to know what your wife's concerns are. Just as if you're talking about anything. It's different from going, all right, okay, so what's your wife really think you're here for? Okay. All right, that's a bit different to what you're saying, implying that they're bobbing the real, avoiding the real issues. So that's one thing that's helpful. With honesty and directness too, which I guess is part of being authentic, you have to sort of share what you really think. We do exercises in our training for no bullshit therapy looking at your family of origin. And some families have a real culture of not being direct. Often it's described as, if you haven't got something nice to say about someone, don't say anything. The sort of about honesty as being warm and caring, but not honest and direct. And then other families might have a view, well, look, being upfront, it's the right thing to do. And if they can't cope with it, it's their bad luck. It's their problem. So then you can be really direct. We then sort of look at how the trainees' families would see honesty and directness, and then see if there's someone in the family or someone in their social network or professional network that's really good at integrating honesty and directness with warmth and care, and use them as a
that's
guide.
good.
And what's helpful about that, rather than just telling someone to combine honesty and directness, is that they can picture that person and they see that whole person and how they use the tone and their approach and their attitude and their values, how they are able to say those tough issues, but in a honest and direct way, but with warmth and care. Maybe it's sometimes it's surprising people in your network who, knock about people that are direct, but their warmth somehow comes through. And then they can embody and just try and replicate that person's sort of approach. The other thing, it's helpful to have some safety strategies, because people worry that if they say the wrong thing and then it gets worse and goes off the rails. And the first is making sure you've got all the 4 clinical guidelines and you're not obfuscating about the constraints or whatever, or that you're combining honesty and directness with warmth and care. The other is being able to focus, like apologize and start again. Sorry if it sounds like I overstepped the mark. That wasn't helpful. Okay, that's helpful.
Oh, that's great.
Let me stop and let's start again. Apologies are undervalued from us therapists. I'm sorry. I really feel like that I unintentionally hurt you, or that wasn't helpful. We can come back to that, or we can address that because we do need to, but in a very different way. So they're just some ideas. I think if you've got some safety strategies in your back pocket, that also gives you confidence to try it out. And then maybe just trying it out. You try it out a little bit and you go, oh, person seemed to really like that. And it made work with clients who I used to find really difficult and maybe frightening. I actually enjoyed it more. And once you enjoy it more, you're going to give that person a better deal. Like at the base of, one underlying attitude of no bullshit therapy is that to make therapy effective and helpful to people who hate therapy as well as people who love it.
Right.
And not to pathologize those group of people that think therapy's a wank.
Yeah, I mean, you have a whole chapter on NBT for therapy lovers, and I really like some of the questions that are very practical in there about, is this what we should be talking about right now? Or is this, how could this be of most help to you? Or, are we still on track? Because you could have situations where there's really good rapport, and which you talk about in the book, that the rapport can be a little bit of a double-edged sword sometimes, because when it's more business-like, sometimes folks are able to kind of open up because they don't worry about disappointing you, so to speak. But once you have this rapport and this strong relationship, then it could get to a situation where maybe they're actually not comfortable because they really care about what you think. And so that might have to be called out, I would imagine, in lots of different scenarios of like, I know that we've have this close working relationship, is this being helpful to you right now? Is there anything that I'm missing? Is there anything that maybe you're experiencing that you might be a little bit, I mean, do you ever do something like that where it's like, is there anything
Yeah.
that we're not talking about because you're worried about maybe what I would think about you? I don't know if any of those lines kind of line up with some of your verbiage.
Yeah, look, I think no bullshit therapy is like for therapy haters, is like single session therapy for therapy lovers. And having the two is a
Mm,
really wonderful combination. And a lot of, some of the inspiration for no bullshit therapy came from what we call the cutting to the chase of single session. Look, and making what I call making time your friend, which creates a safety barrier or a framework to tackle difficult issues. It might be like, okay, so as we said, maybe today will be all that's needed, maybe not, that's fine. But as I said, we really jump in and try and be as, see what you want and be as helpful as you can. So we've only got about 10 minutes left. So can I really be upfront and ask, is there anything that we haven't talked about but we should have before I share what I'm thinking? And I think that's the other element to share what you're thinking in the subjunctive. Look, I've only just met you, so I'm wondering if, and being very clear and direct. But also, again, like a marker in no bullshit therapy, saying, is it okay for me to share what I'm thinking? I've never had a client say, no, I don't want to hear what you're thinking.
right.
I've had clients say, I've been to somewhere else and it hasn't been helpful. Why? They asked a lot of questions and never told me what to do or what they were thinking. Very, very common complaint about previous work. And then if you can share that, like be able to share what in single session work, I sort of think, I encourage people to share with the client what they'd want the client to know if they never saw that person again, rather than hold on to stuff and maybe elaborate and get more evidence for it in the next session or the session afterwards. We know that might not happen. So what would you want to share, knowing that if you were never to meet this client again? And then you're upfront and direct. Clients love it. That's why single session gets such good feedback from clients. And you're transparent and often more efficient and effective because of that.
And I'm looking at the time here. This has been so awesome. I have a couple of final questions here. First of all, I want to say that I really liked your quote. Single session is so compatible with no bullshit therapy. I think of it as NBT with therapy lovers. I think that's really cool. That's so single session. So basically, like single session, it would be really helpful for the therapy lovers. And then, or is it therapy haters? Did I mess that up?
No,
So,
yeah, no,
okay,
yeah. So
let's say it again.
single sessions great with therapy lovers, and no
Yes.
bullshit therapy is great with therapy haters.
Yes, I knew
Put that
I had a
simple
typo
there.
on my note. Yeah,
Yeah,
so single session is very compatible with therapy lovers, and then NBT is so helpful right off the bat with therapy haters.
yeah,
That like blew my mind because Dave and I are in this huge kick that taking a single session approach and using that mindset is one of we call it the secret sauce of
yeah,
primary care behavioral health. And so I'm thinking that in our context, there's so many folks who aren't looking for therapy. They're not looking for it. They end up seeing us for myriad reasons. And to be equipped with NBT, I think is just going to help a clinician working in PCBH to be
yeah.
very well rounded. So this does lead into a question. And I know that you read over some of our materials and have thought a little bit about our context. Any advice for a behavioral health consultant working in a medical clinic, and we don't really get a lot of time. I mean, you could be going in some cases completely cold, or you might have a little snippet from a PCP. You might not really know all the stuff about the scenario. It's fast paced, it's crazy. Is any tips to kind of figure out in your head, if for your conceptualization as a clinician, is okay, are we dealing with a therapy lover situation, or are we dealing with a therapy hater situation?
Yeah. I think like initially you can just engage and maybe gently acknowledge the situation, the context. It might even just be, oh, look, I know that your GP has suggested you come and see me. Can I just check out? So can I just check out? Is that something you were keen or not so keen? So just a gentle thing like that might help you sort of see whether the person's moving towards a therapy lover or therapy hater stance. And if they say, yeah, no, I was really keen, well, then it's pretty obvious. You sort of say, oh, great. So what would you like to walk away with by the end of the next half hour or whatever? If they say, no, I wasn't that keen. Oh, great. Well, good on you for being upfront and direct. That's exactly the way I like to work. Is that okay
Oh,
with
that's
you?
good.
Upfront and direct. And so then you're down towards the therapy, questioning, therapy hater line of the continuum. And so then you can sort of again combine a bit of single session. So look, really, we've probably only got half an hour, so it does mean that we need to probably jump into it. Or no, that's assuming that they want to work with you. So to say, okay, so can I just ask you a little bit more about why you weren't so keen? It sounds like, and maybe saying, look, it sounds like your GP was more keen than you. Because I think that sometimes, in my experience, people come out of loyalty and respect of their GP.
Yeah.
I say, oh, well, Doc Smith said it was a good idea. Doc's been helpful. He's looked after our family for years. I think you're a complete waste of time if they were able to, in the thinking. But Doc Smith's good. And so you then have that sort of like a bullshit conversation where you're having a chat. You sort of know that they don't really want to be there, but they're going along saying the things they think that you might want them to say. But it's a really, and anchored conversation that's not really helpful. And both parties know that it's not helpful,
Right.
but you continue on often out of politeness. And that's where the no bullshit therapy go. I don't like these sort of conversations that we both know are bullshit, but we are not game enough to call it out.
Are you sure you haven't been a BHC in another life? Because that happens all the time, where it's like, I know you don't want to be here. We're wasting each other's time, but we're both so polite and we both love Dr. Smith. So we're just going to keep on doing this. But those are good nuggets, though. Those are really, really helpful nuggets. Speaking of nuggets, I think that you've done a really good job, Jeff, articulating NBT. And it's really cool because I read the main, like been able to read the book and digest the main aspects. Is really, it's a cool experience to read the book and then hear you talk, because there's just so much alignment. And I think that for our listeners, that if you really want to get the most out of this, I think you should read the book. And there's so much nuance to it, and there's so many myths, Jeff, that I don't even know probably how you deal with the amount of myths that people come up to you and say, yeah, I'm doing no bullshit therapy. I just tell the client this or the patient that. It's like, no, this is, way more nuanced. But with that being said, knowing that reading the book is really going to be the only way to get at the right nuance, is there, again, with that being said, is there any takeaway with our last few minutes here, like anything that you really would want our audience to think on? I mean, is it just for tell them to go read the book? I mean, what takeaways would you want our audience members to have listening to this?
I think and actually at the moment, a bit of a plug for your listeners. If they go to the Rutledge website at the moment until the end of April, if they put in CH NBT, they'll get a 30% discount.
And we'll
on
put
board.
that in the show notes of this PCBH Corner. So right
Okay.
underneath it, we'll make sure they have access to all that.
All right, great. And there's also an online training through the Beachy Centre too.
Oh,
Yeah, so that's another way of developing the no bullshit therapy.
if you send me that link, I will put that in the show notes as well so that our viewers can easily have it all in one spot.
Yeah, I think maybe the take-home message is that uh, when you have an approach that it actually works and is respectful with people who initially have bad faith and don't want to work with you, one, you're not so afraid of those clients. For example, I would probably, in my practice when I was doing therapy, I'd have maybe 5% of my clients were therapy haters, the rest were therapy, more towards therapy lovers. But that 5% caused me 95% of my worry time. Are they going to go out and have a crash and smash and kill someone? Are they going to get in a fight? Are they, so having this approach allows you to be more comfortable and less frightened and more leaning into that significant population of the community who don't trust us. And then once you can build a bridge in a really respectful and effective way with someone who's often, especially if there's someone from a group where there's been a historical tension and conflict, it's almost it might sound over the top, it's almost a spiritual feeling where you can reach a joint humanity of effectiveness with someone who you should hate and they should hate you. It's very very rewarding. And also another more practical thing, we often see therapy haters as people who don't want to change. But with no bullshit therapy, engaging in that really direct way and saying what you think and, being upfront about the constraints and, leaning into the person, I've found that they can change, ironically, quicker than therapy lovers. Because they go, oh, okay. Oh, if that's what, makes sense. Are you serious? Yeah. Are you going to do what I suggested or, be upfront, or are you going to sort of forget it, when you walk out here? No, I'll do it. It can change even quicker and more, boom. Doesn't always work that way. And you've also got to know that these are difficult, vexed situations. So sometimes there's no simple solution and sometimes there's no solution.
Right. And, that's the human condition. Not everything is going to work every time. So is there anything else that you can think of before we wrap up that either I should have asked you or that's just lingering on your mind of like, I need to get this out there? Anything else?
Look, there's lots of things, but maybe the only other thing to say is that there's probably a lot of people amongst your listeners who are closet no bullshit therapists who've worked out, if with experience, that this is the way that really works. And a lot of frontline workers in our workshops, they've just sort of worked it out themselves, but often feel that direct approach is not professional and feel guilty about doing it, even though they know it works. So the no bullshit therapy might not be new, but it provides a vindicating and framework and a model that legitimizes that approach. But also, my little challenge is for people in that situation, having a framework actually does help you to develop further, and especially to be able to put it into practice when we're under greater threat or greater complexity.
I resonated so much with what you had talked about in there, that once you start identifying as I do NBT, it does change and your own internal bullshit meter spikes up. And I guess the book just really resonated. I think I absolutely would have fallen into that group of ones where exactly the way you described, where you kind of learn how to work with different folks. And in primary care behavioral health, I mean, Dave and I have run our numbers. In the 10 years of the same clinic, I've seen over 2,500 unique patients. And so when you see 2,500 different folk, you kind of learn what works with certain people and how to word things. And for me, I just found it incredibly helpful to have a framework. And in addition to the framework, it wasn't just that, there were there's specific verbiage and frameworks throughout the book that I actually feel I added to my toolkit. So I just really enjoyed it. And I was so looking forward to our conversation. I was nervous that I wasn't going to be able to, completely summarize or completely digest the book. Not saying that I did, but at least I feel really happy as you were talking. I'm like, yes, I remember what chapter that was. And yes, everything you were saying made a lot of sense to me. So I'm just really appreciative of how eloquent your writing was and eloquent you are here on this PCBH corner.
Oh, thanks, Bridget. And yeah, lovely talking to you, and keep up your good work with you and your colleagues' work too.
I appreciate that. All right. We will be signing off for now, but Jeff, I'll stay on with you for a second after I hit the stop button.
All right, great.